Very good evening to all. Welcome back to our Department of Medicine lecture series under DOMAP. This is the fourth of our lecture series under the Endocrinology. Today's lecture will be by Dr. Nitin Kapoor. He is a professor in the Department of Endocrinology, CMC Vellore. So has completed his DM and postdoctoral fellowship in endocrinology at CMC Vellore. He has also completed, following which he has completed his PhD research on clinical and genetic indicators of obesity from University of Melbourne, Australia. Sir, that actually been conferred with multiple awards. To name some, it being ARC Gold Medal by Endocrine Society of India on 2020. He has also been awarded the Young Investigator Award by Sri Lankan Endocrine Society in 2019, Melbourne Research Scholarship over 4 years till 2020, and then also been awarded the Gold Medal of the Tamil Nadu Dr. MGR University in Endocrinology. He's been also awarded the A.V. Gandhi Award for Endocrine Research, IGM Award for Award for Excellence in Endocrine Writing, and multiple other awards. So he also authored multiple publications, more than around 130. So the areas of interest is in the field of obesity and metabolic syndrome, pituitary disorders, metabolic bone disease. So has also spearheaded the write-up and editor for the current and previous edition of a Practical Guide to Diabetes Medicine 2018. For today's lecture, we have the topic approach to patients with obesity. I hope this is mainly meant for people at the level of PG, medicine PGs, but then it's been open to all. This lecture will be for next 1 hour. If any questions or doubts through the session, you can drop down your doubts in the chat box or ask sir directly. This lecture will soon be uploaded in our Department of Medicine YouTube website also. Over to you, sir. Thanks, sir, for accepting for taking this lecture. Thank you, sir.
Thank you, Dr. Anju, for that very kind introduction. And thank you, Department of Medicine, for inviting us for this series of lectures on endocrine disorders. Over the next couple of minutes, I will take you through this topic of management of obesity, a clinic-based approach. And I would cover this topic in broadly 5 headings. I would briefly just mention about the problem statement of obesity in India, globally in India, and specifically some of the work that we've done here in Vellore. We'll talk about how the Asian Indian phenotype of obesity is very different from the West. And then I would move on talking about what is new in obesity and how we today assess obesity, not by just looking at figures and numbers of BMI and waist circumference alone, but we are actually giving a much broader overview in assessment of obesity. I would then move on to the core aspect of my talk. How about the evaluation and treatment of a patient with obesity, which would be the main focus of this talk, and what are the insights of what we've learned through the obesity clinic that we have here in Vellore. And just before I close, I would also talk about the emerging role of genetic testing in patients with obesity. So to begin with the changing trends of obesity prevalence, and today in terms of the way we talk in terms of pandemic, I would say that many disorders like obesity and diabetes have been in pandemic proportions globally, even before COVID-19. And when you talk of obesity and look at Western literature, this is data from the United States, where we know that about 2/3 of the American population is either overweight or obese. And when you talk of the Indian scenario, we know that obesity does affect all the different age groups. This was a study that we did in school children in Vellore a couple of years ago, done by one of my colleagues, Dr. Rahul Bakshi, where we looked at 304 adolescent children between the age of 12 to 16 years. We studied obesity parameters in them as well as in their parents. What we found was that about 30% of school children. Now, Vellore is not really a first-tier city, it's a second-tier city. And despite that, about 1 in 3 school children in the classes of around middle school and senior school had obesity. So that's how common it is in children. When we talk of adults, and this is data that I'm showing from the Vellore birth cohort. I'm sure all of us here know Vellore birth cohort is one of the oldest birth cohorts that we have in the country, wherein we've been following up people right from their birth. They are about 40 years of age now. And what we've seen in the last phase is that there's a rampant increase of the prevalence of obesity, especially in women, from 30% to a whopping 71%. Even an increase in men, but the prevalence has just rapidly increased in women. This is in adults. What about elderly? And this is from a data which we've more recently published from the community. This is elderly postmenopausal women. When we look at the mean age of this study, it's about 61 years. And when we look at the prevalence of obesity here, again, a large proportion of elderly postmenopausal women from the community have obesity. So obesity has indeed touched different age groups across in the Indian setting. When you look at our hospital-based practice, so what kind of patients actually walk into our clinic, and this is data from the obesity clinic that we run here in the endocrine department with several other specialities. And when we look at the kind of demographic details of these patients, we see that a large proportion of these patients are in their fourth decade. And again, 79% of them are women. About 40% from in and around Tamil Nadu, and that's the usual prevalence of demographic pattern that we see in our hospital from the south as well as the northeastern part of the country. But contrary to the usual belief where we say that obesity is a disease of the rich and the educated, we see that about 46% of the patients are not even graduates. They're up to 12th standard in their educational status. About 1/5 of them are unmarried. Amongst those who are married, about 1/5 of them have primary infertility. We see a huge spectrum of different BMIs and weights, but a large proportion of them have a poor quality of life. So cutting a long story short, we're talking of a pandemic proportion of a disease which is affecting different age groups across India, predominantly in women, not sparing the rich or the poor, and overall affecting the quality of life of these patients. So it is definitely a big problem that needs to be addressed. But when we talk of obesity in terms of the Indian scenario, in terms of an Indian phenotype, we know that things are different. So when we have a patient who is sitting in front of us in our clinic, we have to find out whether our patient would fit into the bracket of normal weight or would fit into a bracket of overweight or obesity, or in the far end of the spectrum, we would see whether the patient has morbid obesity. Now, there are two important things that help us determine this, where our patient is going to fit. One is the kind of obesity indicator that we are going to use, and the second, the cutoff of the obesity indicator that we use. So based on these two things, we are going to stratify and put our patient either as a normal weight patient or somebody who has overweight or obesity, or in the far end of the spectrum where they have morbid obesity. Now, by and large, worldwide, the most common obesity indicator that has been used is the body mass index. It was described by a Belgian mathematician way back in 1832, almost 200 years ago, and it's been fairly well in use all throughout. But over the last say 2 decades or so, there has been emerging literature to suggest that BMI is not one of the best indicators of obesity that we see in our practice. And this was very well replicated in this classic Lancet paper by Dr. Yagnik in 2004, where he described it as the YY paradox, where we see Dr. Yagnik, who's an Indian origin endocrinologist, and Dr. Yudkin, who's based from the UK, both have exactly the same BMI, 22.3 kilograms per meter square, normal by all kind of classifications. But when you look at the body fat percentage for Dr. Yagnik, an Indian origin with the same BMI, has 21% of body fat, as compared to Dr. Yudkin with the same BMI, just 9%. I would say less than 20 is normal. So this overall has led on to a new term and a new concept in the Indian scenario, where we talk of something called as normal weight obesity, wherein people would have normal BMI but high body fat percentage. When we look at the worldwide literature with respect to normal weight obesity, we see that the prevalence ranges from as low as 3% to as high as 21%. We recently studied this in a big cohort in the Kerala Diabetes Prevention Program. And what we found was that about 51% of patients in this particular cohort had obesity. Another 49% were non-obese. But when we look at the body fat, when you look at the body fat percentage amongst the people who are non-obese, amongst 2/3 of these people who had actually a normal BMI had much higher body fat. Now, why should we worry about this? When we looked at the metabolic parameters in individuals with normal weight obesity with respect to diabetes, hypertension, dyslipidemia, we see that it was significantly higher in people with normal weight obesity as compared to obese people, but it was very similar to those with overt obesity. So this is indeed a very common phenotype that we may often miss in our clinical practice, but may have very significant metabolic complications. We actually followed up these patients for 2 years and then looked at what is the impact of a lifestyle intervention on them. And these patients tend to be very, very rigid. There was improvement with the lifestyle intervention that we did, but overall, these people are either inherently more resistant to change, or probably 2 years wasn't adequate enough to kind of improve it much more significantly. So again, the important point here is that yes, the Indian phenotype is very different, and we cannot just copy paste whatever is available in the Western literature to our clinical practice, and therefore we need more and more data coming from the Indian setting. And overall, how our thinking has changed over the years. We have stopped looking at obesity just by somebody's BMI or somebody's waist circumference. Today, we talk of obesity assessment beyond numbers. So over the years, what we've been taught in medical school, we've been taught that yes, ethnicity plays a role. Today, we talk of ethnicity-specific cutoffs. We've derived cutoffs from the Indian setting from our own data sets. But then what the world today is moving across is that we redefine obesity, give a much more holistic approach to obesity, and then talk of the comorbidities. So I'll give you an example, and I'll talk about 2 patients who actually walked in to the obesity clinic on the same day, coincidentally. Our patient A was a 37-year-old lady. She's got a BMI of 41.5 kilograms per meter square. She's got new onset pre-diabetes, which was not there before, A1C 6.2, impaired fasting glucose. She's not on any medications. Her blood pressure is normal. She's got borderline cholesterol levels. She's been advised lifestyle modifications for that. And her ultrasound is normal. There's no fatty liver. Coincidentally, on the same day, we had another patient, subject B. She's got, again, almost similar age, 36 years old. She's got a BMI of 43, slightly more than the other patient. However, this lady has florid diabetes. She's got HbA1c of 9%, which was recently diagnosed. She's already on metformin. She's been known hypertensive, already onto antihypertensive agents. She's got dyslipidemia, and her ultrasound is showing us grade 2 fatty liver. So we see that these 2 patients are almost similar in age, almost similar in BMI, but one lady seems to have florid complications of obesity, whereas the other patient is just having borderline causes. When you look at the lifestyle and the diet in both the patients, it was actually very similar. When you look at the body composition of these patients, this is through the DEXA scan that we do, and we see that the body fat percentage was slightly higher in the patient who actually had a little lower BMI, but it's the visceral adipose tissue, which was really, really different. The visceral adipose tissue was much higher in the lady who had the metabolic problems as compared to those who did not have the metabolic problems. Now, it's not possible in our day-to-day clinics to measure visceral adipose tissue. However, there are different kinds of formulas. The way we don't measure eGFR, we don't measure GFR for all our patients, but we do measure eGFR in practice to staged kidney disease. Similarly, there are different types of parameters that can be used, but I'm not even talking of that, but what I'm talking of, something that can be used even in a mission hospital or a very peripheral hospital, is something as simple as this staging system. Now, Edmonton obesity staging system has been in practice for over 10 years. This has been endorsed by most international obesity guidelines. And what is this system is, it essentially classifies a patient from stage 0 to stage 4, irrespective of what BMI the patient has. Remember, the 2 patients that I showed you had exactly almost the similar BMI, but so different in their metabolic complications. So this kind of a staging system is going to take care of looking into the comorbidities in a much better way. I'll give you an example. Suppose my patient, we're looking at blood pressure. So if I'm looking at blood pressure and the patient does not have blood pressure or hypertension, then I would say that patient has stage 0 disease. If the patient has pre-hypertension, as per definition, I would say it's stage 1. If the patient has already got established hypertension, then I would say, or the patient is on medication, I would say it's stage 2. If the patient has hypertension with hypertensive retinopathy, I will put it as stage 3. If I say it's hypertension with end-stage renal disease, I would say it's stage 4. Now, how is this different? And why is this kind of a classification really important? When we look at the data from the NAINS database, when they compare BMI versus Edmonton obesity staging system, we look at how different is the mortality prediction. Now, this is follow-up for over 10 years. And when you classify somebody by BMI, you can't really predict as to how this patient is going to perform over the next 10 years. You don't know whether stage class 3 obesity would perform worse than class 1. But when you look at the Edmonton obesity staging system, it really stratifies the mortality risk very well. You really know right in advance that the stage 3 and stage 4 are the people who really, really need much more intense treatment rather than stage 1 and stage 2. For example, the 2 patients that I mentioned before, I would probably classify our first patient as stage 2 and maybe for second patient as stage 3. But then the difference in mortality is huge. If both patients are asking for something like bariatric surgery, you know that stage 3 patient would definitely benefit much more than stage 2, even though they have exactly the same BMI. So today, world is moving away from numbers. This has been endorsed by the most recent clinical practice guideline by the Canadian Obesity Network, and it's talking of more and more moving away from BMI, but it's also focusing a lot on giving a much more holistic view to obesity. Just don't look at numbers. Just don't see the weight today is 100 and after 6 months is 100. But overall, has the quality of life of the patient improved? Have the comorbidities improved? And that's also equally important. We recently looked at data on quality of life from our own patients, and it's not, again, the weight. It is several different factors which are affecting the quality of life, and they vary across different severities of obesity, across the different quartiles. So with this brief introduction, I move on to the core aspect of my talk, which is on evaluation and treatment of obesity in the Indian setting. And what we use here is a model called the SECURE model. Now, this is a model which has 3 arms in terms of evaluation and 3 arms in terms of treatment. SECURE stands for S for severity assessment, E for etiological evaluation, C for comorbidity assessment. The URE is the treatment aspect of the arm, wherein U is for lifestyle, urging lifestyle changes. R is the role of medicines and surgery and devices, and E is talking about expected targets. So it's a very simple model, not only used here, but across different obesity centers in India. And I'll take you through this model through each one of these parameters. And the first and the most important thing, when a patient walks into your clinic for obesity management, you have to be able to assess severity. Yes, there are different types of obesity indicators, but as I've highlighted in the previous section of my talk, that it's not just the numbers that you're looking at. Something like Edmonton Obesity Staging System could be done easily, does not require any hi-fi fat measuring machines, not any complex formulas, just good clinical history to try and stratify the patient from stage 0 to stage 4. I'll give you an example of blood glucose values. If you're looking at that, if the patient has normal blood glucose, I would put it as stage 0. If somebody has pre-diabetes, impaired fasting glucose or impaired glucose tolerance, I would say it's stage 1. Stage 2 would be type 2 diabetes established, or the patient is already on medicine. If the patient has some complications of diabetes in terms of microvascular complications, I would say it is stage 3. And if the patient has end-stage disease, so it's like a vitreous hemorrhage, or if the patient has kind of end-stage renal disease, I would say that is stage 4. So that's the Edmonton Obesity Staging System. I've already showed you how effective it is in predicting mortality. So you're going to be targeting your key treatments, like more effective treatments for stage 3 and stage 4. And maybe, you need not provide the same kind of strenuous treatment for somebody in stage 1, even though they may have the same BMI. When we look at our patient population that walks into our hospital, most of our patients actually fit into stage 2 and stage 3. Definitely ours is a tertiary care, and there is a referral bias there. So after we've assessed the severity of obesity, and ideally by an Edmonton Obesity Staging System, the next important factor is going through the etiology of the patient. Now, there are different factors that actually need to be assessed with respect to etiology. Believe me, it's not always the same for everyone. There would be patients who may actually not be really eating much. There's no point giving a didactic lecture to every patient that, this is not what you're doing is right. Regarding your diet or regarding your exercise, it's really important to try and gather what are the key factors in a particular patient that are really changing onto weight. There are several factors described. I highlighted a few which are more commonly seen, but there is an important need to take good history to try and find out, is the patient actually having a problem with the metabolism, whether it's medicines, or whether it's just the dietary aspect, or there are limitations with respect to physical activity. And then we need to make sure that we are handling that adequately. The third aspect of obesity assessment is trying to assess the comorbidities. And I think most of us as physicians are really good in assessing the metabolic aspects. I think through our training in our medical school, during our MD internal medicine, we really trained very well to make sure, we have screened adequately for diabetes, hypertension, dyslipidemia, and the related metabolic disorders. But what we really need to also concentrate upon is the non-metabolic aspects. Yes, the metabolic parameters are known to be high, and we need to make sure we do a good assessment before we embark on any treatment. But when you're talking of the other parameters, the mental and the mechanical factors are equally important. And this is data from our clinic more recently, where we've looked at the psychological burden in patients who walk into our clinic. So believe me, it's about 30%. 1/3 of the people who actually walk into the obesity clinic have an underlying psychological problem. And that's why it's really, really important to get psychiatry in loop. We are privileged for our department of psychiatry, who's been really involved with management of these patients. And believe me, it makes a huge difference to have that counseling done for all our patients. Many patients would either have a night eating syndrome, they would have depression, which could either be a cause of obesity or can be an effect of an obesity. And especially before embarking on more stringent procedures like bariatric surgery, it's really, really important to make sure that our patients have had a thorough psychological evaluation, because these disorders are really common. These were the first three aspects. That is the S, severity assessment, E, etiological assessment, and C is comorbidity assessment. So these were the three aspects with respect to evaluation. We move on to the next three arms, which are with respect to management. Yes, lifestyle change is essentially very important. There's specific guidelines available for the Indian patients. There are a lot of things that we tell our patients. I'm sure this would take a separate class altogether for just highlighting each one of them. But yes, basically inculcating good eating habits, good physical activity habits. One key important thing that I'd like to highlight here is that despite our patients taking a lot of calories, these are patients with morbid obesity that we deal in the clinic, but despite them taking a lot of calories, we still don't meet up the amount of protein required as per the recommended dietary allowance. And that is something that's really important. We know from our knowledge in physiology that taking good protein is essential for getting good satiety. To burn more protein, we burn more calories, and that's important. And the other important thing is it really doesn't work for everyone to just provide a simple diet sheet that this is what you have to eat and this is what you don't have to eat. You have to really give a patient-centric advice. You have to change based on what is really the cultural habit of the patient. You may give something which is very strict and the patient may follow it for a couple of months, may lose a lot of weight. But ultimately, if you're looking for long-term weight loss, you would want really sustained weight loss. And that's possible only once you have a customized therapy. There are different types of diets that are available in the literature, whether we talk of intermittent fasting or daily calorie restriction. But the point that I'm really coming to is that you have to choose the right patient for a sustainable kind of a thing. So if you're trying to manage somebody with intermittent fasting, I wouldn't see somebody with profound diabetes on hypoglycemic agents, as well as somebody with renal and hepatic disorders to go in for that. If somebody is already just eating 2 very big meals in a day, there's just no point in asking them to do intermittent fasting. But somebody like a housewife, somebody who's probably munching all throughout a day, maybe intermittent fasting is better in those kind of patients. So there are different ways, and you have to customize what kind of diet would you prescribe to any particular patient. We move on to the next aspect of your management, which is the role of medicines and surgery. We know that before we go on to that, we have something called as meal replacements that we can use. Meal replacements are essentially just food supplements which are available even in our pharmacy. The basic concept is that it would have about 20 grams of protein, maybe about 150 to 200 calories in a particular meal. Really work well for people who are working, who are not able to cook for themselves a customized meal. But the key advantage of meal replacements is they do meet up the recommended dietary allowance for most of the micronutrients. So even if the patients are taking very less calories, they don't develop nutritional deficiencies. In the US and other Western countries where they give meal replacements, maybe 4 meals a day, maybe 150 calories, 4 meals a day, 900 calories, patient would come back losing 15 kgs, 30 kgs in 6 months. But that's not what really works in our setting. Food in the Indian culture is really a family thing. So if you're going to ask a housewife not to eat any family meal together, it's not long-term sustainable. What we do here is that we ask them to take 1 meal off with the meal replacement and then After that, they are able to lose significant amount of weight, and once they have lost weight, we put them on a meal kind of weight maintenance diet. I never start on meal replacements on day one. We always start with diet and exercise, with the kind of counseling that happens to the nutritionist as well as the physiotherapist in the clinic. Once the patient starts losing, they would come to a plateau. They would come back and tell you, doctor, I have lost 5 to 8 to 10 kgs, but despite the strict, strenuous pattern that I've followed, I'm not losing any more. And that's the point when we have to introduce another supplement, whether it's a meal replacement or a medicine or another kind of a procedure. And at that point, the patient would lose further weight. But if you start right on day one, yes, they would lose weight, but then there would be a point where they would become plateaued up and they would not lose any further weight. There are different data available on meal replacements. This is part of a study that we were involved with, but I know of different studies from Bangalore, from Pune, where they've looked at meal replacements. And it's just not talking about reversal of weight, not only talking about reversal of diabetes, but also talking about very many other metabolic parameters that do improve. Talking of medicines, and there are 5 drugs that were approved by the US FDA. Locurcidin is out of the market. What we use more commonly here is liraglutide and orlistat. Again, liraglutide, we don't have the 3 milligrams approved in India. We can go up to 1.8 mg. The key is we go slow and then we gradually build up. Orlistat should be used only in people who have significant amount of fat content in their diet. So when you have a good dietary recall, only if they have about 20% plus daily calories coming from fat, that's when orlistat works. Otherwise, it is waste. But the key message that I would like to leave for medical management is whenever you start on medical management, you'll find 2 types of patients. You'll find responders and you'll find non-responders, or responders defined as anybody who's lost more than 5% of weight at 3 months. So if your patient has not lost more than 5% of weight at 3 months, they're not going to respond to that drug. You either change the drug or you change your strategy of management. If they have responded, you can continue the medicine. The new kid on the block, or the new drug that is really talked about, is the oral semaglutide, already approved by the US FDA. Is widely used in the US and Australia for management of obesity. It's an oral GLP-1 analog, and therefore it's more convenient as compared to liraglutide. It's going to be launched. It's already launched in India and should be available in the market in the coming months. Talking about other things, as a physician, I would say that it's, again, not just important to look at anti-obesity medicines. It's very, very important to have a good review of all the other medicines. And believe me, it is equally important to promote weight loss by changing the other drugs which might be, making the patient gain weight. We look at other comorbidities like diabetes. I wouldn't want somebody with morbid obesity to be on a sulfonylurea like glibenclamide. Yes, metformin is good, or weight neutral drugs like DPP-4 inhibitors are good. The patient can afford GLP-1 or SGLT2 inhibitors are really good. Similarly for hypertension, similarly for all the comorbidities. So when you are looking at the drug list of the patient, it's important to shift from the weight gaining drugs to something that's weight neutral. Equally important for the antipsychotics. They can cause a significant amount of weight gain, even anti-epileptic drugs. So it's important to have a good review of the other drugs and maybe change over from those which are predominantly weight gaining drugs to weight loss drugs. And that does add on to significant weight loss that you're going to achieve, in addition to whatever other lifestyle measures that we are doing. In addition to this, yes, bariatric surgery is an option. Overall, as per the Western guidelines, bariatric surgery would be offered in those who've tried lifestyle therapy, BMI is more than 40, or if they have comorbidities, BMI more than 35. Yes, the Indian guidelines are 5 less down, and some guidelines even 2.5. So anybody who's 37.5 kilogram per meter square more, or 32.5 plus with comorbidities, there is an indication of bariatric surgery there, but we never upfront to it on the first day of the clinic. There are patients who come, doctor, I have come here only for bariatric surgery. That's not the way it works, because after bariatric surgery, the patient would have a significantly different lifestyle. If the patient has not really practiced that before with a good lifestyle intervention, have not been able to lose weight before, it wouldn't be a good option. Overall, the other options are also like intragastric balloon. This is something that we started in Vellore. We've really had good results in the first 2 patients that it has been done. This is placed in the stomach through an endoscopic procedure, placed for a period of 6 months. Dr. Rajiv and team in gastroenterology are doing a great job. It's removed after 6 months. The first patient of ours actually lost close to 30 kgs. The second patient has also lost 15 plus kgs. And it's a reversible kind of thing. So it's removed after 6 months. The main idea is that during this 6 months, the patient tends to learn as to how to eat less. And thereafter, we put them on a weight maintenance diet. It's not a one-stop cure. Obesity is a chronic disease, requires lifelong follow-up. So with this, I move on to the last part, that's the E, that is the expected targets. Again, what is ideal for you as a doctor or what is ideal as per that patient's height may not be ideal for that patient. There need to be proper, feasible kind of targets that you need to fit. And the first thing that you really need to congratulate your patient is that if the patient was gaining weight continuously and during the next follow-up, the patient is weight stable, you should say that the first thing is that the weight gain has been prevented. Overall, whatever goals you set for the patient are never to the ideal weight. What is still recommended is slow weight loss, which is much easier, which is more sustainable. What we recommend is about half a kg per week or maybe 2 kgs in a month or 10 kgs in 6 months. But gradual weight loss is something that's more measurable. Again, keeping in mind that it's just not a number that we're looking at. We're looking at the overall quality of life. We're looking at the other comorbidities as to how much have they improved, because that's something that's going to have a major impact in terms of mortality. And with this, I move on to the last aspect of my talk, which is essentially talking on the role of genetic testing. And I think we all know that obesity is one of the most inheritable trait that we have. And then when we look at the twin studies, there is a maximum concordance with monozygotic twins. Yes, as of today, the rise in obesity is predominantly an environmental driven, but in countries like India, we still have a component of genetics, and I'll talk to you about in the next few slides. So this was a small study that we had done in community where we looked at 150 mothers and daughters. These daughters are actually married away and not staying with the mothers. Mothers are postmenopausal women, and there is a good concordance with their body fat percentage. But what really makes genetics important in the Indian setting is that we still see a lot of consanguinity in our population in Tamil Nadu as well as in Andhra Pradesh. And based on this, yes, because of the increased consanguinity, there are more and more causes of genetic causes of obesity when we have to suspect them, when you have young onset obesity. And with the availability of the next generation sequencing, it's really affordable. So when you're going to ask for a genetic test, yes, if the obesity has been at a fairly young age of onset, if the patient has morbid obesity, and especially if there is history of consanguinity, history of hyperphagia, history of developmental delay, but that's not always required, and other features of certain syndromes. But then if you're talking of just constitutional looking obesity, which is young onset in a patient who has consanguinity, it's worthwhile checking for a genetic test. There are different types of genes of interest which work on the hypothalamic region that are actually looked at for a mutation. We at Vellore do a 35 gene panel for NGS. But why is it really, really important? We recently looked at our own data, and what we found that about 16% of these patients who have this young onset obesity have these mutations. But why is it important for us to check for that? How will it make a difference? It will, because today we have specific drugs that can really help these patients. So if you have an MC4R mutation patient will have no psychiatric manifestation. They would just have obesity, they would feel like eating more, and they would have morbid obesity. But today drugs like setmelanotide can reduce 20 to 30 kgs in the right patient. So there are emerging specific treatment for these kind of patients. And if you're going to miss them, they would be devoid of such treatment. So with this, I think I come to an end of my talk. Just to summarize what I've spoken was, initially I did mention about the problem statement of obesity. Yes, it's a big problem worldwide, globally. In India, it is affecting all the age groups. Today, we talk of the Asian perspective of obesity, where we are looking at the Indian phenotype. We're talking of a new phenotype called normal weight obesity, which is fairly common and has high cardiometabolic risk. We have stopped looking at obesity just by looking at numbers. Staging systems like the mentioned obesity staging system help us predict mortality much better than just looking at BMI or waist circumference alone. Talking about evaluation and management, the secure model is helpful. We just don't concentrate alone on the metabolic parameters, but psychiatric manifestations and mechanical problems are to be addressed equally. Management-wise, yes, we have drugs, we have meal replacements, we have bariatric surgery, we do have intragastric balloon, but the bottom line is long-term follow-up is important, and it has to be a patient-centric advice. Every patient cannot be covered with the same blanket of treatment. You have to assess the patient in detail and then give an advice. And as neotherapies do keep evolving, there is role of genetics in a few patients. So I'll stop here, but I'd like to acknowledge the entire team of endocrinology with all the allied departments for our constant support for running our obesity clinic. Thank you so much.
Thanks a lot, sir. That was a very in-depth, informative talk on the approach to obesity. I think we have some questions in the chat box.
Right, thank you. So we'll look at some of the questions. So what are your views? The first question is from Dr. Daisy, and that is on what are the views regarding reducing calories versus reducing portions. Also, is fast weight reduction harmful? So I would answer the second part of the question first. I wouldn't say fast weight reduction is harmful, but I would definitely say it's not sustainable. So slow and steady would still be better. What would happen is after a crash reduction in calories, patient would lose a lot of weight, but then at that same time, they would come back to you with symptoms of, doctor, my nails are becoming brittle, I'm seeing a lot of hair fall, I'm not able to work as efficiently, I have memory lapse. So all those symptoms do start setting in. It's always good to go slow, so that way it's good. I would say reduction of calories and reduction of portions both are equally important. So it is not only that one day's calorie is reduced. Rather, there was a study that we were involved with where we just changed the carbohydrate to protein ratio of each meal rather than the whole day. So if you change the carbohydrate to protein ratio of each meal, we are going to provide more satiety all throughout the day. So it's just not the total reduction of calories that's important. Overall, each meal needs to be custom tailored. Moving on to next question, hypothyroidism and obesity. I would say it's a big myth. When we say hypothyroidism and obesity, in garden variety of primary hypothyroidism, the maximum weight gain that you can attribute to the thyroid is just 4 to 5 kgs. You cannot just say that, because the TSH is 10, 8 or 9, the patient is obese because of that. I must also mention that the cutoffs for TSH are different for different categories of BMI. As the BMI cutoffs go up, the TSH cutoffs go up to 8 to 10. So somebody with a BMI of 45, the normal TSH for them would be 8 to 10. So it's important, and there's this paper that I showed in one of the slides that was on the endocrinology of obesity. There's a table as to how the cutoffs of different TSH values vary across BMI. So it's important to treat hypothyroidism if it's present, but subclinical hypothyroidism is often blamed as a cause of obesity, which I would say is not correct. Use of metformin for obesity when there are no comorbidities. So metformin, the amount of weight loss that you can expect is just 2 to 3 kgs over a period of 1 year. I would say the indications are that if the patient has impaired fasting glucose or pre-diabetes with obesity, then you can use metformin. In a non-diabetic individual, I would not start metformin. How do you use EOS in a patient who has more than 2 risk factors? Very good question. You use the risk factor that gives you a higher EOS grade. So suppose somebody has diabetes and hypertension. The hypertension is only pre-hypertension, so stage 1, but the hypertension also, but the diabetes has diabetic retinopathy that makes it stage 3. So I would label that patient to have EOS stage 3. Very good. Good question there. And yeah.
Comments also saying it's a very lucid talk, sir, and then also practical and brilliant. Comment by Professor Murthy from Bangalore.
Thank you very much.
So with respect to having patients who come to our OPD on a day-to-day basis, who mostly housewives who are obese, who can't spare time for other non-pharmacological measures. Any specific inputs into non-pharmacological measures?
Right. So
patients can't make time for.
Right. So maybe 4 or 5 things I'd like to tell. It's really important to get that quantum of oil that the patient uses in the family. So often patients will tell you, doctor, I don't eat any fried items. I don't, get much of oily food into my diet. But when you ask how many people stay at home and how much oil really comes in the house, you would get surprising answers. There would be 3 members having 6 liters of oil, and where it's all going. So it's all that little oil that actually gets in, which goes unnoticed. That's the first thing that I would like to mention. Second, it's important to harness on protein intake. When we look at our North, South, West, or East Indian diets, we are predominantly carbohydrate rich. So getting more protein is important. So simple things like, a snack like sundal is better than something like a tiffin item. Milk, curd, buttermilk, any of these nuts, egg whites, lean meat. So they are rich in protein. So simple North Indian diet, if there's dal and rice, I would tell them to cut down the rice to half and double the dal, or even triple the dal for that matter. Apart from more protein, the third aspect that I would often mention is regularity of exercise rather than quantum of exercise. When we actually ask them to kind of measure the amount of calories that they burn in a gym by running on half an hour, they would realize that they would get that much calorie in just 1 cup of coffee. So what they really need to do is regularity more than quantity. The fourth important thing is, especially educated patients, we'll ask them to kind of use apps which are available. There are a lot of free apps available that not only give the amount of calories, but also the amount of protein intake, so they can actually tailor-made this thing. And fifth thing would be that we try and spread off their calories in different meals and snacks, rather than making them fast for a very long time and they're very hungry and then they eat whatever they can.
More questions have come in. So
Right.
views on keto diet is one.
Right. So I'm actually not a big fan. And when you look at the international literature as of today about all these fat diets that are there, there's intermittent fasting there's keto diet there. The long-term sustainability of any of these diets is actually miserable. So it's not really, it's good for a good acute weight loss. Patients will lose a lot of weight. And but long-term, when you're looking at 5 years down the line or 3 years down the line, the patients would be back to square one. So I would say any diet that the patient can sustain. Keto diet can be done, but if the patient is willing to sustain it long term, if the patient is just going to follow it for a few months, I'm not going to suggest that. Rather, I would say whatever is usually made in the house, how they can change the proportions of that thing would be more helpful for that patient. How to advise an obese patient who has osteoarthritis of the knee, not willing to do TKR? So I have an excellent physiotherapist in the clinic who's really innovative, but a simple way would be, rather than telling the patient to walk 30 minutes, I would tell them to walk 10 minutes, 3 times a day, to use non-weight bearing exercises. And that's helpful. Even upper arm exercises are useful. In young obese patients, can liraglutide be started? As per anecdotal published literature, it has been started in children as low as 12 years of age. The rule is always you start slow and go up very slow. I would never start on 1.8 mg to anybody, young or old. But start at 0.6 and gradually go up, but has been used in younger individuals as well. Will excess protein be harmful to kidneys? Very good question. What is the upper limit of protein? So what I would always tell my patients is, when we look at the protein intake, or we calculate a good dietary recall, and what is normal protein is, say, 1 gram per kg. But when we look at the amount of protein that usually people are taking is much, much less than what is recommended. So you would get just 30% or 40% of what is ideally required. So I never recommend high protein. What I'm telling is, what you can make up to the normal recommended amount of protein. And that itself is very, very useful. Any advice on prevention of obesity? Yes, it's a need of the hour. And getting onto school children, I think, is one of the best ways. Dr. Nihal has done a lot of work in the department and a lot of school children, educating teachers, getting a healthy snack day in schools like Scudder. I think that's the right way to prevent the future pandemic of obesity to worsen.
Any further questions? There is a whole lot of questions for a change. So I think it's kind of a relevant topic for, I think, for everyone. One more question has come in, I think.
Okay. How does BMI correlate with EOS and with body fat distribution? Yes, I've looked at that very carefully. So BMI does not correlate very well with EOS staging, but very well with visceral adiposity, not with the total body fat, but very well with visceral fat. That was actually one of the objectives of my PhD. So can animal proteins be substituted for carbohydrates? So animal or plant protein, the problem with many of the non-vegetarian food is that many of them require a large quantum of oil to be cooked. So it becomes difficult to curb on the oil aspect, but egg whites, fish, lean meat is actually okay. But vegetarian proteins are not bad. Soya and the other items that I mentioned, dairy products, nuts, lentils may be useful. Okay, thank you.
Any
If
further
then
questions? Then it will be mailing, sir. Any questions?
yes, more than happy to answer on email.
And lecture will soon be uploaded on our Department of Medicine YouTube website. Anyone who missed out on a lecture can be accessing this stream over there. Thanks again, sir,
Thank you.
for accepting.
Pleasure.
I think we'll wind up for today. Thank you.
Thank you.